Well, we finish up with the last module of this 54 module marathon. And we're going to be looking at module 54, and specifically these include all the biomedical therapies. There are a number of aspects of this that stand apart from all the other therapies that we have looked at in the last video. And essentially, it really, in many ways, boils down to psychopharmacology, in a sense. And essentially, when we talk about that, let me write this out first before I talk psychopharmacology. Long word, but it is the study of the effects of drugs on mind and behavior, and it has really revolutionized the treatment of people with severe disorders. So effects of drugs, which I often reduce down to RX, on mind and behavior. And in days gone by, as you can recall when we were talking about the history of psychology and the treatment of the insane, it was brutal. It was really brutal, and psychopharmacology has really changed the landscape. So instead of straitjackets, we're talking about a chemical restraint on behavior and hallucinations and other things like that. So essentially, one of the techniques that we often use to evaluate the usefulness of drugs is something that we refer to as a double-blind study, not double-bind. I'll put the L in there. Double-blind study, and essentially what that means is that subjects, the people that are participating in the study, and the staff that are doing the study have no idea whether they're administering a placebo or whether they are administering the live substance, if you will. So subjects and staff are blind to the conditions of the study. And that's key, because we are trying to essentially interfere with the expectation effect and the aspects that would impact placebo effects. If patients know that they're getting something that is supposed to make them better, and it's just a placebo, then we end up getting what we refer to as a placebo effect. A double-blind study makes it so that subjects don't know and the staff who administer the drugs don't know, and because of that, then our hope is that we would get a clearer understanding of how the drug actually acts. If you've ever participated in a double-blind study or a drug study as a subject, the people that come in to administer the drugs have no idea. All the tubes or injections or whatever are all labeled blankly with just a number. So they have no idea, and neither do you. So in the biomedical therapies, generally psychiatrists are really the only one, and they have an MD degree. And in most situations, they are the ones that are administering the medication, biological treatments when it comes to psychology or psychiatric treatment. So psychiatrists are usually the only ones. There are a few smaller incidents or cases where people other than MDs are administering drugs. In the military, as a matter of fact, at least in some cases, PhD psychologists are able to do just psychoactive medications only, but that has continued to be quite a point of contention between the medical profession and even the psychology psychological profession. Now, let me break this down into 3 different drug classes, and then we'll turn our attention to some of the things that we refer to as psychosurgery or even brain stimulation. So first of all, we have antipsychotic medications, and for the longest time, if you've ever seen antipsychotic drugs, if you've ever seen A Beautiful Mind, he was placed on Thorazine. Thorazine was, or chlorpromazine, was one of the drugs of choice in antipsychotic medication. It tamped down the hallucinations and a lot of the positive symptoms of schizophrenia and other psychotic disorders. But ultimately, the side effects here was such that the person had something that we refer to as Tardive Dyskinesia, which is involuntary movements of the tongue and limbs, and dyskinesia. And this was one of the side effects of the antipsychotics. Most of them would block the dopamine receptors, and that's what produced this. That's what would produce these involuntary movements of facial muscles, tongue. A lot of times there's what it looks like they're sticking out their tongue, but they may roll their tongue. There may be movements in their hands, like pill rolling behavior. If you see a thumb in your forefinger and you roll it over the top of it, you'll see that kind of behavior. Some of the newer psychotics have fewer of these side effects, which are really quite positive, help a lot, but the side effects also increase the risk of obesity and diabetes. So there's no drug really. Bottom line is this, to keep in mind, is that there really is no drugs that have no side effects. Even if you take higher doses of Advil, which we consider fairly safe to take, you're going to have GI tract side effects. And those are part of the backdrop of what we talk about when we're talking about side effects. All drugs have them. Whether you're entirely aware of them or not is another matter. The second class mentioned in your book is anti-anxiety medications. Excuse me, anti-anxiety meds, and my X's here are not very good. Medications, and these, a good example of this one is Xanax. Another one might be a drug called Librium. One that you may be familiar with or having heard is Valium. Many of these are anti-anxiety medications. They depress the central nervous system activity, and they can be quite, the downside of these is their addiction potential is quite high. And that's something that doctors have to take into account when they're considering the cost and the benefits of medications like this in the case of anxiety. And there's a relatively new anti-anxiety drug that ended up being an antibiotic, D-cycloserine, and it acts on a receptor that, in combination with behavioral treatments, facilitates the extinction of learned fears. So ultimately, the criticism that comes out of all of these really is essentially the message that a drug can fix me rather than the work that I have to do personally to get better. And that's part of the downside of some of these medications. As a matter of fact, in most of my practice, in working with people over the last 3 decades or so, I basically said to folks, look, I am not real crazy about the medications or using medication. There's work to be done, and we need to focus on that. If there is a point where it gets so overwhelming and interferes with your work or relationships or things like that, then we may buy time by using a medication, but that's a short-term solution. It is not a long-term solution. The last one is an antidepressant, and antidepressants have been in use for a very long time, but they have changed considerably. Their aim is not to make you happy. It's not happy pills. It's to stabilize mood and to help people feel or get out of a hole so they can make some headway on some of the things that we talked about earlier with cognition and things like that. So a good example would be of the drug that we use a fair amount of is Prozac. Now again, we have the same problem we had before. It's a class of drugs that's called SSRIs, Selective Serotonin Reuptake Inhibitors. They are increasingly being used to treat anxiety disorders like OCD, but they've also been predominantly used in treatment of depression. And the Zoloft is another one that you may have heard of. Zoloft, Celexa is another one. Lexapro is another one. And all of these essentially block the reabsorption and removal of serotonin from the synapses. So if you remember back to the synapse where we had the synapse, and this goes down to the axon here, and these are small receptor cells, and serotonin sits in the synapse and fires according to need. This is the axon, this is the dendrite. And essentially what SSRIs do is they block the reuptake of the serotonin so it stays in the synapse longer, and thereby impact the mood that is increased or elevate the mood, or to stabilize the mood in some cases. These do, as with many others, they have side effects. Dry mouth is an example. Weight gain is another one. Loss of libido might be another one. And they are effective, but you have to live with certain side effects. And essentially what a psychiatrist does when they evaluate a patient is they evaluate them in terms of these side effects plus the positive effects of the medication itself. And that's very much a part of the landscape when we're talking about using medications in psychology. The last one I want to mention as part of this is lithium. Lithium is really just a salt. It comes in a form that oftentimes you might refer to as lithium chloride. Sodium chloride is table salt. Lithium chloride is also a salt. It has a very effective mood stabilizer for people with bipolar disorder. But again, there are side effects. Weight gain is one. Acne is another. Feeling numbed out is another one, and that's all very much a part of lithium. But lithium is a little bit different class of drugs. It seems to be very effective with bipolar, but some newer bipolar medication has come onto the market, and they're anticonvulsive drugs. So what you might notice is that there are medications that are being used that not their initial purpose. We call it off-label use. And anticonvulsants oftentimes end up being very helpful in stabilizing mood as well. And those are things where psychiatrists, when they do medication checks, they're checking on to see how the person's doing, if they're struggling with suicidal ideation and all those things. that are part of the landscape when we introduce a medication into somebody's system, physical and psychological.